a consultant in this area. He's also a medical oncologist. He will introduce Dr. Damiano to you and undivided attention, which I'm quite confident all of you will have, so that you get the best of it. Okay? Have a nice day.
Thank you, ma'am. Good afternoon. It's my privilege to invite Dr. Damiano Rondelli, whom we have been working for the last many years to grow hematology and bone marrow transplant at Ramaiah Medical College Hospitals. He will definitely talk more about our collaboration. At the same time, educate you more in the area of hematology and stem cell transplant. He is a well-known physician in the United States in bone marrow transplant hematology. He heads the division of hematology oncology at USC, and he has numerous publications in international journals to his credit, and also he's a able administrator and a very good doctor whom we fall back upon for advice whenever we have difficult patients that we are managing. Welcome you, Dr. Damiano.
Thank you. I expect none of you to know anything about bone marrow transplant. So if you do, forgive me. Try to be quite basic and simple, but also I hope to trigger in some of you at least some interest. This is an extremely fascinating area of our clinical work and research. So this is actually the one slide that is important to me. So from a global perspective, bone marrow transplant, as I was telling you in a few seconds, is a curative procedure for many diseases of the blood. Can save lives and cure patients. But as you can see here, is mostly done in high-income countries, States, Canada, Japan, Western Europe. And if you look at the number of people in this map of the world, the majority of the people in the world have very low access to a bone marrow transplant. In fact, if you look at just, the colors, the more intense is the more the rate of transplants. In the blue, so in the United States, more than 500 transplants per 10 million people are done. More than 500 transplants per 10 million people. If you look at India, for example, it's probably less than 50 million people, and now has increased. Before it used to less than 20. In many areas of Africa, it's zero. So look at Nigeria. Nigeria has 200 million people, like 2/3 of the United States. I think they do 2 transplants a year for the open. So the need of transplant is a real need and is a real action opportunity for many patients to be cured. How do I do next slides? It's open. It's open. So this is only to show that, as expected, the reason why the transplant is not done in many areas of the world is because of the costs and also because of the training. Many areas of the world don't have training in hematology, don't have training in bone marrow transplant, and therefore people cannot have it. In addition to that, the cost. Here an idea: if a transplant in Chicago, a stem cell transplantation from a donor, we'll see the difference between patient and donor right now. It's about $300,000 to $400,000 one transplant. Okay, and we can make the math with less, less. But in Bangalore, I don't know, it's about $30,000, $30,000 to $50,000. So almost 10 times less. And still, this is very expensive for many patients. Now, I'll come back to this issue at the end of the talk, just to give you like a very basic information on what, can you see? I'm in the middle part. What's the best part for me to say here? Right, then to be like, so bone marrow transplant is a transplant of stem cells. The stem cells are the cells you probably have studied in biology. Stem cells are those cells in the bone marrow. Very few of them. The real stem cells are called. The real stem cells are the two cells called pluripotent stem cells that are very rare cells in the bone marrow that have two possible options to do. One is to replicate themselves without changing, to maintain a pool of stem cells always present in the bone marrow. And another part is very early stem cells can proliferate and differentiate, which means actually they will be able, down the line, to become any of the blood cells that at the end will get into the peripheral blood. So they will be split between lymphoid and myeloid. And then within the myeloid cells, you can have the neutrophils, the eosinophils, the monocytes, and basophils and so on. And then they also make platelets too. So when we do a transplant, we want to transplant this subset of stem cells. Where do we find them? In the whole bone marrow or in the cells that come from the bone marrow. So what is this for? As I mentioned before, the reason why we do bone marrow transplant can be to cure. It's not a palliation. It's not trying to try to make some in a few months of life. It's to try to cure diseases in the oncology side of the blood cancers, like leukemias, myeloid neoplasms, called myelodysplastic syndromes or myeloproliferative neoplasms, lymphomas, and myeloma. But also, it's very useful, especially in this area of the world, for diseases like non-cancer, but very, very severe, very bad, thalassemia, sickle cell anemia, and plastic anemia. These three diseases, for example, the incidence of these diseases is a lot higher in this area of the world than in Europe and the United States. And I'll show you some data on, for example, on sickle cell. That's fine. So we talk about transplant. We talk about two different types of transplant, which are completely different. The autologous stem cell transplant and the allogeneic transplant. The autologous, next. The autologous transplant is where actually the patient donates his or her own stem cells for the transplant. So the question is, what's the point? What's the point of donating stem cells out of a patient and putting them back in the same patient? The point is, it's a very nice trick that people invented many years ago in order to give a high-dose chemotherapy. If you give a high-dose chemotherapy to any cancer patient, and I'm sure that you see patients, either friends or family or somebody you know, getting chemotherapy. The major limitation of the chemotherapy is the toxicity that the chemotherapy has, especially on the bone marrow. If you give a too high dose of chemotherapy, the patient white cells will be down to zero forever. The patient will die of infection. So the limit of the chemotherapy dose very often is based on the possible toxicity to the bone marrow. However, if a higher dose of chemotherapy was very helpful to the cancer, but you cannot do it because it's too toxic on the bone marrow. How do you fix this? You fix it by doing an autologous transplant. We take the stem cells of the patient out before the high-dose chemotherapy. We give the high-dose chemotherapy. The next day after the chemotherapy, the patient gets the stem cells back, looks like a transfusion in the blood, and the stem cells will repopulate the bone marrow regardless of the high-dose of chemotherapy. So in this way, the autologous transplant is basically a high-dose chemotherapy with a rescue of the stem cells. This is next. On the contrary, the allogeneic transplant is a real transplant. A real transplant is when we put something from someone into others. The person giving the bone marrow or stem cells has to be genetically fully or partially matched to the recipient. And we'll talk about what does it mean. But if you are familiar, if you heard about liver transplant or kidney transplant, how do you know who among you know what's the compatibility based on? How do you know if someone can receive a liver? So, liver transplant is only based on ABO match. The only thing you care about is the blood group. Nobody cares about the HLA. In the bone marrow transplant, in the stem cell transplant, we don't care about the ABO group. You don't have to be compatible for the blood group, but you have to be compatible for the HLA or partially compatible. That means that the donors could be a family member or CQ, or somebody outside the family. There's a worldwide donor registry bank for people who signed up, and some of you did, to be potential donors for somebody else in the world. So right now, I think around 40 million people. And this would be an unrelated donor. The indications for transplants, how many transplants are done for what disease today, look like this. So the green bars are actually the autologous transplant. As you see here, it's mostly done in multiple myeloma patients or in lymphoma patients. You may not, I don't know if you know what multiple myeloma is. Do you? Does anybody know? It's cancer of the plasma cells. Plasma cells, and that's how central computing. But anyway, multiple myeloma, as the bone marrow transplant is a standard of care in having myeloma patients. Instead, the donor transplant is mostly done in acute leukemias, myeloid, sometimes lymphoid, or chronic leukemias, or in non-cancer patients like aplastic anemia or thalassemia, and so on and so on. Next slide. This is the United States numbers, but they reflect actually the numbers around the world. You see over the years, the last 20, 30 years, the numbers have gone up a lot for both autologous and allogeneic. So the numbers are going up. The number of patients getting transplant increased. And they increased because we have learned how to do it. To patients who are older, and to patients who are sicker, and to patients who are not compatible with the donor. Still, we can do it. Next slide. Next one. So compatibility, so we said before HLA, the compatibility that we require for a transplant has to be based on at least 5 type of antigens. I know you probably understand somewhat about the HLA. But, so we all have class 1, 2, and 3 HLA antigens. We don't care about the class 3. We look at the class 1 and 2. In the class 1, the antigens that are looked at for compatibility are A, B, and C. DR, the Q. Now the people has the DR and the Q. So everybody has 2 sets of antigens, each set of HLA antigens for each type of antigen. So we have 2 HLA-A, 2 HLA-B, 2 HLA-C, and so on. So when we look at H compatibility, we look at 10 total antigens, 5 couples, 5 A, B, C, DR, and Q. So to be compatible, someone should be compatible for all of them. Next slide. Yes. So how do we know that? Every person, each of you, has 2 sets of antigens on HLA antigens. One you got it from your father, and one you got it from your mother. So this is dad and this is mom. And they both have 2 sets of HLA antigens, and they're all different. So the children will inherit half from mom, half from dad. So the combination of the HLA is basically follows a Mendelian transmission. So they will have. So how many people can be compatible to each other? 25%. Next slide. So our patients. So then that first information, only siblings can be compatible. Only siblings from the same parents have a chance to be compatible. And this chance of being compatible is about 20%, 25%. Next slide. However, if we were to look at who could be half compatible, almost everybody is half compatible to each other because every child inherited a half of the set HLA from mom and dad. So they will share. So in this case, for example, this patient here will be half compatible with both parents and with 3 or 4 of our siblings. So Today, we can do transplants from donors who are half compatible. This was not the case until probably 10 years ago. But for the last 10 years, we learned how to transfer. So what that means is that almost every patient can find a donor. And here, I didn't include fathers, uncles, grandparents, their own children. So people can find a donor almost, not all the time, but very, very few. Just briefly, if some of you is interested in immunology, I'm not sure, but the reason why we can do transplant in incompatible patients 10 years ago was a no-no. People would die in a week. If you were to do a transplant in an incompatible donor from an incompatible donor, the patient would die of immediate immune reaction of the donor cells against the patient, which is called graft-versus-host. We will talk about it. But now today we can do transplant in incompatible donors because somebody very smart learned that the T cells that cause this huge inflammatory process, killing the patients, they proliferate very quickly after the transplant within 3 to 4 days. So on day 3 and 4 after the transplant, we block those T cells with a high dose of immunosuppressive therapy. The incompatible transplant gets run, and the patient actually has an outcome comparable to those who actually have a transplant from incompatible. With a huge change, huge achievement in the transplant work. And this is done by this technology called post-transplant cyclophosphamide. Next slide, please. Next slide. So, how do you get out the stem cells? When I was your age, and you're older than you, I would go twice a week in my training program as a fellow. I would go twice a week to the OR to harvest this photo here. To harvest the stem cells from the bone, to take the bone marrow out of a patient or a donor under general anesthesia by doing many small aspiration from the bone, from the iliac bones, both sides, about 40 holes in the bones of the people. And we collect about a liter or liter and a half of bone marrow, which would contain all the stem cells. The patient or the donor would have some pain when they woke up after general anesthesia, but it was okay. For the last probably 20 years, we have learned actually that we can move the cells, the stem cells that live and reside in the bone marrow. They don't travel, they don't flow in the blood. But we can release them from the bone marrow, like the sudden release, by doing two things, either by giving chemotherapy to the people, to the patients, or by giving, much easier, growth factors and granulocyte growth factors called GCSF, which has the ability to detach the ligands, the additional molecules that keep the stem cells attached to the bone marrow very temporarily for a few days. So we give the patients 5 days of these shots. It's a subcutaneous shot. The stem cells are released in the peripheral blood. We can count them. We can look and measure them by flow cytometry. And then we know that they're enough. We collect the cells from the peripheral blood, and that's the machine here. It's not version, but this machine, the patient goes through this collection with a liquid product. The stem cells are collected. This bag can be frozen in the lab for 30 years. You don't need to keep them for 30 years, but can be frozen for a long time. Patient then can go to the transplant when he's ready. The cells will be thawed and infused in the patient. Next slide. The cord blood has also been used in the past. It's been almost abandoned. Women delivering the baby would donate the cord blood cells. Some umbilical cord would be aspirated. The stem cells inside the cord blood are very powerful stem cells. But for children, it was okay. For adults, you would need more than one cord blood, and it's very expensive. Also, so it's been almost abandoned. What we learned over the years, actually, we can transplant patients up to 80 years old today because we know how to reduce the dose of chemotherapy. And so the number of transplants go down because until 20 years ago, people above age 50 would not be a candidate for transplant. So, next slide. Next slide. So, just very quickly, why we do this. This is, for example, our survival curves in multiple myeloma. Without and with and without the transplant, the autologous transplant. You see here that it doesn't take a statistician to see that this actually curve is better than this one. Next slide. These are the results in patients who had Hodgkin lymphoma. Hodgkin disease is a cancer of the reproductive system who failed chemotherapy and had this and autologous transplant as a rescue after the chemotherapy, when the chemotherapy failed. And you see here that now the outcome is actually very good with these high-dose chemotherapy and the rescue of the stem cells. That's fine. And this is actually for this other non-Hodgkin lymphoma, very common aggressive non-Hodgkin lymphoma, which is another cancer. And you see that the transplant is actually curing our patients. Next slide. Next slide. Next slide. Everyone. When we do a transplant from a donor, the risk of dying is about 15 to 20%. The risk of dying on the transplant. Why? Not only because the patient can also have a relapse of the cancer, but also because there are complications that can be very severe. Infectious complications, organ toxicity from the chemotherapy. So these patients are very frail. They are completely immunosuppressed, completely zero. So they are at risk of having an infection. That's why they have to be in a protected area, like the one we have here, the transplant unit. They have to be on a lot of antibiotics. They have to be very careful. Next slide. How does the transplant work? This is the standard way that it's been translated from the left. The transplant was invented, by the way, in the 70s. The one who invented the bone marrow transplant got the Nobel Prize in 1990. His name was Dan Thomas. He was in Seattle, and he got the Nobel Prize for developing bone marrow. The process is quite simple. The patient receives chemotherapy or radiation therapy, or the combination of chemotherapy and radiation therapy for 3 days. The next day, this transplant is done by infusing the stem cells in a central line, like a transfusion, but through a central line. And what happens after that is actually the white cell count. This is a red triangle here is the red cell, the white cell count. The white cell count will go down to 0 because of the chemotherapy. And the cells of the donor that has been transplanted here, it will take about a couple of weeks. They start working. They will start making new cells in the blood from the donor. And so you see here, there's a gap of time between the cells of the patient getting down to 0 or below 500 microliters, and the cells of the donor to come up. So this gap of time here is when the patient is very susceptible to infections. That's nothing there. It's transfusion. They are fever. So that's a chemotherapy. That's a transplant that has a high dose chemotherapy and a prolonged time of 0 neutrophils, 0 down once I come. Next slide. Over the time, we have learned that actually the transplant can be done with less chemotherapy and still be okay. And what we saw with what we call reduced intensity transplants is less hard with the chemotherapy, but more tolerable to the patient. Or, next slide, even what we call a non-myeloablative regimen, like kind of a very light chemotherapy or even no chemotherapy that has the purpose to allow the donor cells to engraft. The reason why do we do something like that has no chemotherapy, very low chemotherapy? Because the donor transplant has 2 weapons. The only one thing you want to remember from this talk is this. The transplant from a donor is based, the reason why we do it is not the chemotherapy. The chemotherapy helps, but the reason why we do it because we want the donor immune system to attack the cancer. We want the donor immune system to become a new weapon that the patient did not have before. So it's a very clear immunotherapy by using the donor immune system. So if you can allow the donor immune system to engraft, be part of the patient, even with low chemotherapy, that's in some diseases, in some areas actually is very good. Next slide. These are a bunch of different regimens that I need to describe to you. So this is a summary of this part. So where do we use each one of these regimens? A strong transplant. You do it in a young patient. You will all become here, need a transplant, you get a myeloablative transplant. If patient actually who have an aggressive disease, if you have a high risk leukemia, you want to use all your weapons, both the immune system and the chemotherapy. And also some patients who don't have comorbidities. If someone has already, a borderline kidney function or a borderline lung function, you don't want to give them too much chemotherapy. Whereas the other ones can be done in patients who are older Or, especially the non-myeloablative, the patients don't have cancer. If you don't have cancer, you don't need chemotherapy. So the only purpose of chemotherapy is to make sure that the donor cells can establish themselves, can engraft, and make it. Next slide. An example of this actually is about sickle cell. And I say because we have a specific interest in Chicago, but sickle cell anemia is also present in Asia. And in fact, you see here, the incidence of sickle cell is mostly in Africa, with pockets of sickle cell in the Middle East, in India, and I'm here. In the United States, there are 100,000 patients in all the United States, 100,000 patients with severe sickle cell anemia. We cure them with a transplant. In this area of the world, there are almost no transplants, so nobody can be cured. In Nigeria only, this area of the world here, there are 5 million patients with sickle cell. Next slide. So we have developed a transplant program actually in our center where we cure sickle cell with a transplant without chemotherapy, zero chemotherapy, only we only immunosuppress the patients. And we can actually achieve it in engraftment sufficient to have patients being cured for life. Next slide. Now, the major issue of a transplant, the major issue of a transplant actually is the only transplant that exists where there are 2 immune systems, one against the other. When you do a kidney transplant or a liver transplant, there's an organ, the kidney, that gets into the patient, and the only thing that the patient can do is try to reject the new organ because it doesn't recognize the immune system of the new organ. So the patient will get an organ transplant, heart, liver, kidney, lung. They have to stay on immunosuppression for life, otherwise the immune system of the patient will have rejection. When we do stem cells, when we transplant the stem cells from the donor, we transplant a new immune system. So the 2 immune systems will have to find a balance to get along, because it's a mutual attempt to reject each other. The rejection of the patient against the donor is a standard rejection. The rejection the other way around is called graft versus host disease. The graft is the donor against the host. The risk of graft versus host disease is a much higher risk than rejection. Why? Because the patient got chemotherapy. So the immune system of the recipient is already very weak compared to the immune system of the donor, which is very strong. So GVHD is a major risk for these patients. Next slide. What happens is you're very knowledgeable immunologist. 3 different things happen. It is a very simple scheme. When we give chemotherapy, we create damages in the organs. We have the cells break down. They release everything. They release cytokines. They release antigens. They release pieces of the cells that become exposing antigens on the antigen-presenting cells, like the dendritic cells, like macrophages, like Kupffer cells, micro cells in the skin. These antigen-presenting cells, loaded with antigens, will meet the donor T cells when the transplant is done. So the T cells from the donor will find a beautiful silver plates of antigen exposed to them, and they will react. Even if they are compatible, they're not identical. So they will start reacting against these antigens in a standard indirect response. So the T cells would become activated in response to the exposure T cells. Produce a bunch of cytokines, pro-inflammatory cytokines, TNF-alpha, TNF-1, TNF-17, and so on. And then we'll differentiate into effector cells, like NK cells, or lymphocyte activated killer cells, or cytotoxic lymphocytes. And they will, at that point, they don't get more against them. They go to the organs and attack and kill the organs. So the major target of this immune reaction in the acute GVHD setting is the skin, the gut, and the liver. So patients can have an acute GVHD of these organs, and sometimes it's lethal. To prevent that thing to happen, we have to give immunosuppressive therapy to the patients after the transplant. Next slide. The acute GVHD is more commonly observed within the first 3 months of transplant. And then there's another form of GVHD called chronic GVHD, which is different. it looks like any autoimmune disease that you know, that can actually start earlier, can start later, can be prolonged for a long time, can also be a threat to the patient. Next slide. Next slide. Chronic GVHD is a very difficult animal to deal with because sometimes it's very, it can start very slowly, it can affect any organ of the body. From the eyes, dry eyes, like a Sjogren, if you have studied any autoimmune disease, but you can look any autoimmune disease, from the eyes, the mouth, the thyroid, the skin, the nail. The most dangerous form of chronic GVHD is when it affects the lung. The lung GVHD, of course, makes the patient not breathe. And the patient actually become very frail and they eventually die. Sometimes they're candidate for a lung transplant, but then they become too sick. So it's a very difficult disease when that happens. Fortunately, it's not that common, but that's funny. So the way we do explore the chronic GVHD is a very technical thing. For every patient going to transplant, we have to monitor every organ based on scales of grading that has been developed to monitor to know how difficult, how severe, how risky it is the condition. And so that based on that, we change our therapy, the immunosuppressive therapy that we give with multiple agents. Next slide. So the major treatment of GVHD remains steroids, unfortunately. Sometimes at a very high dose and for a long time. The challenge has been actually how to improve on that, and actually very interesting new drugs for GVHD. You don't need to know them, but there's a breakthrough in the treatment of chronic GVHD, which I think also in many autoimmune diseases, which is very, very impactful. One has been actually glutamate, which is an anti-B cell drug. It's a kinase inhibitor that actually has been shown to be effective. But the B cells, I didn't go through. I was very fast, but the biology of the chronic GVHD, it's based on activation of the B cells by the T cells. T cells actually can create this B cell activation that can create these cytokines like fibroblast growth factors and other factors that can cause fibrosis, scleroderma, organ toxicity that actually is hard to target with one drug. But the most effective drug that's been recently really demonstrated in a randomized study and actually approved by the FDA in the United States, the standard of care now is the next slide. A JAK inhibitor. JAK, but you should know this. You're students. You know what JAK does. So every cytokine that we most of the cytokines actually that bind to our cells. The signal that the cytokine gives to the cell is through, after they bind to the receptor on the surface, they activate domain under the cell membrane, initially through JAK. JAK signals them to STAT. STAT goes to the nucleus and activates whatever the cytokine cells. This is a very common path in many inflammatory processes. So the development of drugs that actually block JAK, they were developed for a different purpose, but anyway, so we have these drugs, has now become very effective in many autoimmune diseases, in particular also in chronic GVHD. So the outcome actually is improved in people who do not respond to steroids, who die. Actually, at least 50% of that can be arrested and improved on JAK inhibitors. Next one. But the future of transplant, and this has been a very superficial review. The future of transplant actually is not only bone antigens, T cells. The future of transplant will be gene therapy. Gene therapy has been developed in some diseases. This is an example actually of an initial experience in thalassemia and sickle cell disease, where actually it's not actually gene therapy, it's the wrong term. The right term is gene editing. Because we don't replace a gene, but there's an editing on the gene. So in sickle cell anemia or thalassemia, the problem, as you know, is there is a congenital abnormality of the hemoglobin. When the baby is born, what's the hemoglobin of a baby before the baby is born? So why after the baby is born, the hemoglobin changes? But what gene actually triggers the shift from hemoglobin F to hemoglobin A? There's a gene. This is activated at birth. It's activated. Hemoglobin F shuts down, and hemoglobin A goes up. That gene is called BCE11A. So, for the most part, decided actually to edit this gene and to make sure that people who actually have sickle cell with thalassemia, if we can block BCE11A in the stem cells, the cells, what will they do? Make again hemoglobin F. And if you make hemoglobin F, that can be actually a very valuable way to cure or to treat sickle cell or thalassemia, because the hemoglobin S or the lack of hemoglobin A is replaced by hemoglobin F that actually can be a surrogate hemoglobin very effective. This concept was developed, was done by using CRISPR technology. As a CRISPR technology is way to do gene editing without using viruses. And the first 45 patients have been treated with this therapy in two clinical trials. The first two patients actually were for a year of follow-up were recorded early in 2021 in the New England Journal of Medicine. And next slide. The results actually are quite outstanding. Most of the patients have a normal hemoglobin and they are cured. And these are autologous cells. So these are basically their own stem cells, gene edited. So this is the future of stem cell transplant. Just for you to know how you decide to become a transplant physician. Next slide. So the only very few slides at the end. I gave you a very superficial and quick outlook of what transplant is. But I started saying the majority of these things happen in some areas of the world, and many other areas of the world have access to. Major reason why transplant is not yet available in many places. It's a combination of reasons. There are not enough infrastructures. There are not enough hospitals that can afford or can put together a bone marrow transplant unit. There are not enough understanding of the need of this transplant. In many countries, I'm not talking about India, maybe outside of India, but many countries, there's not really sense of how effective or impactful would be to cure people with leukemia, to cure people with thalassemia, to cure people with aplastic anemia. There are no registry in these countries to know what the burden of disease is. There are not enough medical doctors trained for this. So there are no doctors, and some people, sometimes people try to invent themselves as transplant physicians. I've seen that in other countries, and the results is a disaster. The people die. And then the major limitation actually the costs. So the socioeconomic factors that are part of the equation. And even if it's low cost here, it's still very expensive. Next slide. So what we did, what I've been doing here, the reason I'm here, actually, because I've been working on this issue for many years, and it's very close to my heart, how to support the development of more places where this actually transplant can be done in a fashion, though, that is actually a high level of standard. Otherwise, if you do a cheap way, medical tourism is not often a good solution to diseases, because people can become surgeons even without training, can become transplants without training. So the quality of the program is actually the guarantee for the patient to survive. So we developed this program in several countries where we try to partner with people and launch clinical trials and programs, and actually this prominent example. They do an amazing job here. You don't know it, but the bone marrow transplant program here is fantastic. Next slide. There's lots of activities that we've been doing, like training and exchange with people. People coming to Chicago, we come here, educational events, and so on. Next slide. These are the countries where I'm working with. Just doesn't matter. India is on top. Next slide. And this actually was started here at Ramaiah in 2014. It was decided to start a new transplant program from scratch. And this actually has been going on for now every 4 years. and Dr. Santosh and Dr. Markme are amazing assets to this program, and they should be recognized as an asset, major asset for the whole campus. And I hope somebody will rotate in their unit at some point, just to see how it looks like. That's right. There's also been a huge improvement over the years in the teaching hospital for the hematology and oncology area. So the patient actually got less infection and survived. It's amazing of this hospital. Next slide. The first data were to reported in a very prestigious journal from Ramaiah a few years ago. And actually, next slide. And this is the numbers. Actually, you see the numbers have been going up. And there's business COVID. Despite of COVID, the transplants continued. A few patients left, but actually it never stops. So these numbers are going to go up again, and so we need people. Next slide. The bigger issue is studying, not only talking about, but also studying and learning how to address in low resource areas, how to address the cost of drugs, the quality, the training, infectious diseases, GHD, stem cell work, and so forth and so on. This is actually the plan for the future, but this actually is a big reality that allows many countries, many patients to be cured, when 10 years ago it was not even an option. This is part of my slide. Yes, thank you. Hope you have questions. Thank you. Questions? Any questions? Please. Yes. Please.
It's actually related to the medicine part of it, not exactly the you talked about the granulocytes, polysympathetic factor, which you inject to release the stem cells, right? The chemotherapy is done to inject these stem cells back into the bone, right? How does it exactly work there? Like, it should reach the bone back in order to do its work, or can it do its work?
You mean you're asking how the stem cells go back to the bone marrow to work?
Yeah.
So when you inject this, it's a good question. When the transplant is done to a central line, usually in the subclavian, the central line, the cells are going circulating the blood. It probably takes, it's been calculated, it takes probably between 1 to 2 days, the journey of the cells. They eventually travel, and they go back to arrive in the bone marrow. When the stem cells arrive in the bone marrow, they find specific receptors that basically put them there. CXCR4 is a major cytokine receptor, adhesion molecule. So when the LFA1, these are adhesion molecules that stem cells express, and when they find the partner on the microenvironment in the stroma on the bone marrow, they stop it. They cannot follow you. So they takes about a day or two. They get there, they stop there, and they start working.
Some other person's bone marrows are injected. Does that happen to the other?
So you ask if it happens when they are rejected?
Yeah.
Yes. So the rejection can happen for 2 reasons. We don't call it rejection. We call it graft failure. So most of the times they are rejected by the immune system. So the cells are there, but there are antibodies or T cells from the patients, residual from the patient, that can attack the stem cells and decrease them so much that they are not able to make them. Or the stem cells that are transplanted are not enough by the time they go to the bone marrow to start a significant production of our blood cells. In that case, we call it graft failure, which would be, so what we do in that case, we give a strong immunosuppression, thinking that maybe it's a T cell mediated process. And giving a lot of steroids, a lot of immunosuppression sometimes helps, but sometimes if the stem cell pool has been already depleted, even if you stop the immune response, there's not enough cells left over. In that case, it's US transplant.
What is the path for a undergraduate student to want to become a hematologist or transplant physician?
What is the path for an undergraduate our students to become a bone marrow transplant physician? All of it, no. So the path is, it's a joke, but it's not a joke. I mean, but the reason why someone can be interested in this area is for a scientific purpose. It's a very fascinating field. If you think of transplant of immune systems to get together into new technology, new therapies, immunosuppressive drugs. I didn't have the time to go, but there's many different aspects that are really changing very fast. One actually I didn't mention, just so the path is to be fascinated by these things, intellectually, but also from the patient care. To see these patients being cured is very rewarding. These are patients who actually are not really much else to hope, and you provide a cure that is actually quite amazing. One of the things we started with in the United States, but also many other areas, is actually to utilize oncologists to get the T cells of the patients. This is now done as a standard in lymphomas. Take the T cells of the patient, gene edit these T cells by transferring into these T cells a receptor to make them express a receptor for B cells. So now the T cell has a B cell receptor, but otherwise they shouldn't have it, right? With the B cell receptor, a T cells can bind to a B cell, which is a lymphoma cell, a B cell lymphoma. But then also make sure that these T cells are super activated by transfecting one or two costimulatory molecules, 451 or CD28. So these T cells are bombed that as soon as you get injected in the patient, they are only T cells activated and capable of reaching the B cell lymphoma cells. So these cells are called CAR T cells, chimeric antigen receptor T cells. This has been done. The success of these T cells in engineering is done in patients who have failed every chemotherapy, everything. They're after 3 lines of chemotherapy. When the patients are basically can only die. With this process, at least 50% of the patients are cured, and some of them actually had the chance to go to a transplant after. This was started shooting in children with leukemia, acute leukemia children, lymphoblastic leukemia children who actually had 6 months to live. Most of them were cured. So these are like an early stage of a new technology, which is going to change completely the world of cancer. Not only B-cell lymphomas, probably will be applied to also some of the organ types. So if you're passionate about these things, if you think this is going to be a very cool technology, biotechnology, gene engineering, immunology, and oncology, and taking care of our patients, that is how we get into this care. But it's not enough. You need to find somebody who actually gets you through the door. The door meaning not politically speaking, but the door of knowledge. So you need to start looking into who does that, shadowing these people on here, get in the clinic if you really like it, and asking questions. And because this is a field that's changing very quickly, and to be part of that, I feel very lucky to have gone through this process. And for a long story, but I think that many of you, if you are exposed to this, you will love. If you love taking care of patients, and if you love being intellectually challenged, this is an area that very fascinating. Actually, there's a training component to that. So most of the people who transplant are trained in hematology. But in the United States, the hematology and oncology are done together. Here would be a DM in hematology. But then there's a training also, which has been developed in the United States by the American Society of Transplantation for BAT training transfer training. So these programs are available for 1 year. People can, after the transplant hematologist, can be trained in only transplant for looking at every single aspect. So the training will become more and more important because there are so many things to learn. I think I learned 95% of what I know from people, from physicians, from other people who show me and learn, and then you have to keep up with whatever kind of happens. Enough? Yes.
Like what exactly is the objective of a BMT? Like is it to stop the disease process or to replace those?
So the objective, as I mentioned in the beginning, is to cure the patient. The only exception is multiple myeloma, where we try to it's an incurable disease, so to make the disease as long as possible. But the objective is to, in the autologous setting, is to cure with chemotherapy. In the allogeneic setting, is to cure the patient with provided the patient with an immune system that will control the bone marrow of the patient and also hopefully avoid the relapse of the disease. So have an immune response against the cancer, which is called graft versus tumor.
But if you are going to replace that with a donor cell, then how does the body stand a chance against the donor cells? Because we are going to give immunosuppression to like prevent the host disease.
Yeah,
But then
still it happens. Still there are lymphocytes or immune cells somewhere in the body that can still be reactivated and can still be able to reject. It's very rare. The rejection involving the stem cell transplant from a matched sibling is probably less than 5% or less than 2%.
How does the body accept the incoming stem cells?
How do they? So how do they accept the incoming cells? There are many theories about that. The reason was because if you freeze the recipient immune system by giving chemotherapy and immunosuppressive therapy, the new cells, the donor cells, will populate lymphoid organs, which cause what is called peripheral tolerance. Eventually, even central tolerance. They may go actually to the thymus and remake the thymus, process the immune system from the donor perspective. But also, the peripheral tolerance can occur in the lymph nodes, in the spleen, and this has been studied for many, many decades. How peripheral tolerance can occur.
no, but initially when you transplant the donor stem cells, you have to suppress even those, right? Because they can attack our body initially.
Why do you want to suppress? So you suppress the donor cells.
Because they will be attacking our body initially, right? Before they develop tolerance.
Right. So the balance of this. So we don't want to kill them. Otherwise, there's no point in the transplant. So we give it what we call it prophylactic immunosuppressive therapy with cephalosporin or with other agents for a period of time. That is not killing the immune system, but it's just keeping the immune system of the donor a little bit more calm than what they should be. It would be without any immunosuppression. Then eventually we can stop completely the immunosuppression, and the donor and the patient will be fine without any infection. Usually, we don't consider the immunosuppressive therapy for more than a year, as opposed to kidney transplant.
But we also need it to be active to act on the tumor cells, right? So if we are going to suppress it,
So that's the balance. So that's it. I give you, a ton of T cells. They're going to kill the cancer, but they can also kill the patient. So we keep them, instead of giving them like 100% strength, we give them a prophylactic immunosuppressive therapy with cephalosporin, so they actually active up to 80%. That would maybe decrease the anti-cancer effect, but still very valuable. But we'll protect the patient, otherwise it will die. When we see that it's actually, when we do less than points, we decrease the dose of immunosuppressive therapy. And if we look at the patient. If they don't have any reaction, then we taper off the immunosuppressor and then stop.
but does that mean that you need lesser immunosuppression for it to be restricted to the tumor cells?
Ideally, if you do not have the immunosuppressive therapy, you would probably a stronger effect against the tumor cells. Yes, but you cannot afford it. This patient will die. Yes.
Is that understood?
Yeah. It's a balance. In fact, the immunosuppressive therapy has changed a lot now, so that's another thing. All right. How many of you want to become a bone marrow transplant physician? All of you. All right. Thank you very much. And good luck. I have that. Thank you.
Yeah,